Hello, everyone. It's good to be here with you today. We're going to be talking about some very important topics related to cancer screening. I'm Liz Popwell, the Chief Strategy and Transformation Officer here at Stony Brook Medicine. And today we have a panel of experts that are going to talk with us about the importance of cancer screenings and talk a little bit about some of the wonderful care that we provide here at Stony Brook Medicine. I'm going to go ahead and ask each of our experts to go ahead and introduce themselves. Dr. Dhamija, would you like to go first?
Hi, thank you. My name is Ankit Dhamija. I am an assistant professor at Stony Brook University and work for the Cardiothoracic Surgery Department. I'm currently hold the title of Director of Robotic Thoracic Surgery and excited to share my experience today with everyone here about lung cancer and screening.
Thank you so much. April, would you like to go next?
Hi, so glad you can join us. I'm April Plank. Thanks for joining. I'm one of the nurse practitioners here at Stony Brook. I've been here for many years and happy to co-direct our lung cancer screening program here at Stony Brook.
Great, thanks, April. Dr. Georgakis, would you like to go next?
Good afternoon. My name is Georgios Georgakis. I'm a hepatobiliary surgeon and surgical oncologist here at Stony Brook for the past 6 years.
Thank you. And Dr. Nagle.
Hi, I'm Deborah Nagle, and I am the Chief of Colorectal Surgery here at Stony Brook. I've been here for 3 years, and I'm very thrilled with the growth of our division and the care that we're able to offer cancer patients.
Thank you so much. Just as a reminder, there was a QR code that we flashed up at the beginning of the session. Feel free to go ahead and drop a chat if you have a question for one of our experts, or if you have something that you'd like to send in anonymously through the QR code. By all means, please do that. We love to have a good interactive discussion. So thank you all for joining us today. We're going to go ahead and get right into it. The first topic we want to talk about is lung cancer. I know Dr. Dhamija talked about thoracic cancer. That's the same thing as lung. And April, can you talk a little bit? Let's start with Dr. Dhamija. Would you please share a little bit about lung cancer screening? Why is that so important? And who is eligible or appropriate to be screened?
Sure. So lung cancer screening is the most recent screening that really exists. Really, it's a scenario in which patients that are candidates that have been previous smokers in the past that potentially can be candidates for lung cancer screening. We started screening here at Stony Brook in approximately 2013, and at this point we have about 2,000 patients in our program. About 3% of the patients that ultimately are diagnosed with lung cancer from the people that we screen. So there is a percentage of people in which we find them. The benefit of this is the fact that you are able to technically find these cancers in an earlier avenue. And that allows you different robust options of treatments to be able to offer to a patient. Additionally, lung cancer can also be seen in patients that do not have a history of smoking. For example, some of the other risk factors include radon exposure, occupational hazards such as asbestos and silica, and even 911 exposure. Also, if you have a family history of lung cancer or lung disease such as emphysema, or even other cancers in the body, you tend to have an increased chance and likelihood of cancer as well. Once diagnosed, we often verify that that somebody has a lung cancer diagnosis with a biopsy. After that, we go through staging with PET scans to verify that the patient has an early stage disease. Given the patient's overall health and the options that exist for treatment at that point are either surgical resection or localized therapy with radiation or cryotherapy. We also offer treatment for advanced stages of lung cancer with improving survival with chemotherapy and targeted immunotherapy. Some patients with advanced disease may also become surgical candidates after these therapies. Our preferred approach for early stage lung cancers is to utilize the Da Vinci robot approach. This is generally done with small incisions, and patients leave the hospital relatively quickly in anywhere between 1 to 3 days on average. This approach is associated with the faster recovery, and there is higher magnification, which allows for a finer dissection, thereby leading to a lower likelihood of converting to a larger incision, which is traditionally referred to as a thoracotomy. And additionally, in my opinion, you're able to have a more precise lymph node dissection. And as many of you know, lymph nodes are key to completing the staging of lung cancer.
That's great. A lot of wonderful information there. I appreciate it. April, I wonder if you can expand a little bit more on our program, how it works. I know cancer is a scary thing, and there are a lot of unknowns when you're a patient and a family member. So talk a little bit about our program, talk a little bit about how we help patients understand their care plans, and what does that look like from your perspective?
Okay, sure. So as Dr. Dhamija said, lung cancer screening is recommended for those who are at higher risk. And the guidelines are pretty uniform across the board. If you're 50 years old or older, and if you're a current or a former smoker, and you have to have smoked a certain amount of cigarettes, we use a calculation called PACHE years. You don't have to be a mathematician or figure that out. You can call our office and we'll help you through it. But essentially, if you smoked about a pack a day for 20 years or a half a pack a day for 40 years, that would be equivalent to at least 20 pack years. So once we establish that you meet criteria for screening, and we do that over the phone, then we schedule you for a low-dose CAT scan. So lung cancer screening is done with a low-dose CAT scan. It's a much lower dose than a regular CAT scan. It takes less than 5 minutes to do. We set it up for you to have the scan, and then here at Stony Brook, you can either get your results same day, you get preliminary results same day and the official results within a few days, or you can wait a few days and get the results, at a convenient time for you. We love to meet our patients in person, but for those who are not able to, we're happy to do telemedicine with you. And lung cancer screening is recommended every year, low dose scan, until you are about 15 years out from that last cigarette. So if you're currently smoking, it's continuous. And if you were able to quit, if not, it's okay. There's no judgment here. I think we're going to talk a little bit about smoking cessation, but many of our patients say that they were a little hesitant to come in because they're still smoking. We recognize how powerful of addiction, nicotine addiction is. And we're happy to help. Most of our team are nicotine addiction specialists, and we come alongside and help you with beginning your journey to quit. And even if you're not able to quit, we recommend this screening every year. We've screened, like Dr. Dhamija said, over 2,000 patients, and we have about 3% of them that have been found to have lung cancer. We have story after story. Our patients don't have symptoms. Remember, the lungs are not very innervated. There's not a lot of nerve in the lung. That's why lung cancer is often found late. So with lung cancer screening, we can find small cancers. We found cancers as small as 6 millimeters, which is real tiny. If you haven't looked at a ruler lately, look at how small that is. And to be able to resect that cancer with either the robotic technique or another surgical resection, you are technically cured, and we follow you then ongoing every year after that. So yeah, if any questions, we're always available.
Wonderful. Thank you. I know we put the phone number up for more information. Dr. Dhamija, I'd like to ask one other follow-up question. You talked about chemotherapy and immunotherapy and how that helps improve outcomes for patients. Can you explain to our viewers I think a lot of us know what chemotherapy is, but what is immunotherapy?
Thank you for that question. So immunotherapy is a more modern technique that people are using to be able to target certain types of treatments and certain types of cancers. Every cancer has its own biochemical profile. And what happens at Stony Brook and other university hospitals is that they're able to run biomarkers on the tumor tissue themselves to be able to then subsequently target those immunotherapy options towards those biomarkers. So, for example, if somebody was to have a lung cancer or a specifically adenocarcinoma of the lung, you may test the patient for a specific marker called PD-L1. And if their PD-L1 numbers are a higher percentage than normal, you may be a candidate for immunotherapy. Immunotherapy then allows us to further target that therapy and provide even longer and sometimes maintenance or therapy over the long run to basically keep things at ease. This is something that's offered here at Stony Brook itself, and that's kind of a summary of immunotherapy and its use.
That's great. I think that's very helpful for people to understand a little bit more about that. So thank you. I'm going to switch topics and talk a little bit more about a different type of cancer. We're going to switch to pancreatic cancer. And Dr. Georgakis, we'd love to hear from your perspective on, what is pancreatic cancer from the layperson's perspective, and what are the symptoms, and how do we care for and treat for those patients?
Unfortunately, pancreatic cancer is one of the cancers that are more difficult to detect in the human body, and mainly because the pancreas is in the back of the body and it does not give symptoms until the cancer becomes a little bit bigger. So people who suffer from pancreatic cancer, sometimes they do have vague pain that they cannot explain otherwise. Sometimes they can get yellow, they can get what we call jaundice. They lose weight. If they have diabetes, it can get worse. If they don't have diabetes, they may have an early onset diabetes. Sometimes they can have diarrhea, or their stool could be a little bit pasty or different in color. And there is a multitude of symptoms that they may have that a lot of times people dismiss, because as we get older, things happen to us and we don't think that it's something important. However, when the pancreatic cancer settles, and we see people with pancreatic cancer all the time, only 10% of these patients will be able to live after 5 years, which makes it one of the most lethal cancers that we have right now. Unfortunately, we do not have a lot of tools to early detect these cancers, and the only tool we have right now is a very heightened application of our diagnostic tools right now. There are no many cancer screening protocols for pancreatic cancer. There are several genes that we know that these patients will definitely develop pancreatic cancer, but unfortunately, unless someone has something in his family that we know that they will have more chance of developing pancreatic cancer, the other patients with pancreatic cancer, they get into the category that we find them incidentally. The earlier we find the pancreatic cancer, the better it's going to be the prognosis. If we find the pancreatic cancer very early at a stage which is going to be stage 1, sometimes they can have a 5-year survival from 25 to 40%. Unfortunately, when the stage goes higher, the survival rate goes lower. We do offer at Stony Brook a lot of screening protocols for patients that we deem to be high risk. Also, we do have a lot of protocols that we survey pancreatic cysts that sometimes they can be precursor for pancreatic cancer. We do treat pancreatic cancer in a team fashion. We have a tumor board to discuss all our cases there. We have medical oncology and gastroenterology that we perform very complex cases. And we also perform the surgery in a minimally invasive fashion with a Da Vinci robot that makes the patient have less trauma and go home sooner and be able to start their treatment pretty faster than with the techniques that otherwise are employed.
That's very helpful. Can you talk a little bit about some of the people and demographics that are more susceptible or more likely to be at risk? And I know there's sometimes environmental factors as well. Can you explain some of that to us?
Yes, people that smoke, they do have a high risk of getting pancreatic cancer. People that are obese, they have a high risk of getting pancreatic cancer. Several genes that they are abnormal, they make people have pancreatic cancer. The more two common genes for making people have pancreatic cancer are STK11 and CDKN2A. So these genes, they definitely have to be screened for when patients have them. And the only way for patients to know that they have these genes is that if someone else in the family have pancreatic cancer, and this patient who has pancreatic cancer, they have been diagnosed with these genes. When patients have these two genes, they definitely have to be screened with yearly MRI and another test that the advanced gastroenterology team is doing. It's called endoscopic ultrasound. These tests, they will investigate the pancreas and they will find sometimes precursor lesions that will pretty much identify things that you can act upon. When act upon means to get a biopsy and identify if this lesion is definitely cancer or it has been a dysplasia that potentially needs to come out. If we find cysts that they have been followed up for a long time and they're stable, most of the times they're not dangerous. However, sometimes when cysts, they grow or they have in their mucin that it can be a precursor for cancer, this cyst can also be a problem, and this cyst can also potentially be removed. And sometimes if they harbor cancer, the cure rate could be pretty high.
Thank you so much for that. I know, Dr. Georgakis, we talked a little bit about the surgical approaches, some of the treatments. You've talked a little bit about some of the screenings, especially if you have a high risk from a family member who maybe has had this disease. Are there other cancer screening processes at Stony Brook Medicine that we could talk about? I know we've got a phone number if people have other questions about whether they're at risk, but are there other things that patients should consider? And what does that look like when they come into the office and talk with our experts?
We do see a lot of patients that they have other cancers. For example, patients that they have, women that have breast cancer and they have BRCA positive gene. So these are genes that they can also be risk factors for pancreatic cancer, and they are worried, will I develop pancreatic cancer? Unfortunately, there is no answer that can tailor all the patients. Everybody different, and we have different protocols for every patient. So when a patient comes in with this question, we'll first get a very detailed history, and then we'll pretty much ask about any family history. If they don't have a genetics consult, we'll get a genetics consult to see if there's any other genes that are concomitant, or if they have any genes that they can be either this one or additional to the one that they have. And depending on the guidelines, we'll pretty much try to treat the patient according to the guidelines. Sometimes, though, the guidelines are not enough because not for every gene the guidelines suggest screening. In these cases, we have to use our clinical judgment to identify which patient has a higher risk than others in order to be able to get some of the diagnostic modality that we have. An MRI or an EUS are the first things that we will try to employ, especially if there's a lesion that we can find in there. We do have a team of surgical oncologists. I have two partners. And at the same time, we have a nurse navigator who's going to be the point person of the patient, that she will guide the patient on every step that they have. We have a nurse practitioner who's going to be the first point person for every medical question the patient has. And our cancer center has a multitude of specialties like psychological services. We do have dietitians. We have a very good team of medical oncologists. The whole group is geared towards helping patients with these diseases.
Well, thank you so much for that information. I'm sure that has been very helpful for our listeners. I'd like to circle back now. We've got a question that has come in about the lung cancer processes. And so I'm going to ask Dr. Dhamija if you'll address this question. Are there external signs and symptoms that someone should come in for a lung cancer screening? For example, they're asking about yellow tongue from smoking, yellow teeth. Are there any cosmetic side effects of smoking? Is there anything that our consumers and our viewers can think about when it comes to those kinds of elements?
That's a great question. So historically, people with lung cancer, traditionally prior to any sort of screening protocols, started coming in with coughing of blood, or if the mass is large enough that they were short of breath, or that it was compressing some nervous structures, causing them some discomfort down their arm. Those are the general, more common risk factors initially that somebody would look for, and then subsequently get a CT scan or a chest X-ray looking for what the causes of that may be. In today's date, unfortunately, what the lung cancer screening, or fortunately, what the lung cancer screening allows us to do is actually prevent those cancers from getting to the point of what the other symptoms I had just described were. And this would allow someone to basically act upon it such that you can get control of the cancer in its earlier forms. The specific symptoms that were described in the question, specifically the yellow tongue from smoking or yellow teeth, are secondary effects of the nicotine and the effects of cigarette smoking in general. Those things, unfortunately, aren't any specific signs of lung cancer, but do break down enamel and other things that may cause issues with discoloration. Some of the other things that can be associated with smoking as well are healing and other risks of other cancers, as well as Dr. Georgakis just mentioned regarding pancreatic cancer as well.
Wonderful. Thank you so much for that answer to that question. I'd like to switch now to colon cancer and colorectal cancer. And honestly, this is one that's near and dear to my heart. My mother passed away in her late 50s due to colorectal cancer. And so me and my 3 siblings have been screening since we've been, each of us, the age of 35. And I know that's so very important when it comes to colorectal cancer. So Dr. Nagle, again, your specialty is something that has really touched my life and my family's life. Can you talk a little bit about what screening looks like here at Stony Brook Medicine?
Sure. Unlike other diseases, there are multiple options for screening for colorectal cancer. The gold standard has always been colonoscopy, and that's what's been recommended for patients starting at the age of 50 until recently, when we found that younger patients are getting colorectal cancer. And now the recommendation is start at age 45 for average risk patients. That means no one in your family has a history of colorectal cancer, and you haven't previously been told you have polyps or other GI diseases that could increase your risk. So we start with screening at age 45, and colonoscopy is the recommended test. But we know that patients are often reluctant to have a colonoscopy. It is just not anybody's favorite test. So there are other alternatives for screening besides colonoscopy if for some reason you just can't see your way to a colonoscopy. So there's tests that can be ordered through the mail so that you send a kit to the patient's home, and the patient can send a sample in for testing, and that can indicate whether or not the patient needs to have a colonoscopy. That test has become more popular in the last few years because of ease of use and the fact that you don't have to be bowel prepped in order to do the test. That said, if the test comes back positive, then you really must have a colonoscopy. There are other tests that have been used over time, including tests for blood in the stool. That is a test that is not super specific, but it's, again, easy to do and easy to sort through and find people who really will most likely benefit from a colonoscopy. We, through all of our practices at Stony Brook, offer all these kinds of tests to our patients. And whether you're engaged through your primary care physician, whether you're referred to a GI doctor, or whether you see a colorectal surgeon, all those tests are available.
Great. Thank you so much for that information. And we have a question that has come in about the frequency of screening. So how often should someone get a colonoscopy if they have a family history of colon cancer?
So the rule of thumb is every 5 years, unless there are findings on the colonoscopy. And the way you determine when you're going to start screening with a family history is you take the age of the person in your family who had colon cancer, subtract 10 years, and start at that time. So if your parent had colon cancer at age 50, you're going to start screening at 40. So that's the general rule of thumb. If that scan or if that colonoscopy is negative, there's no findings, no polyps, no concerns, then you're going to go every 5 years. If something is found on a colonoscopy, like a polyp, for example, then the next screening or the next colonoscopy is based on those findings, and could be anywhere from do it again in 1 year or do it again in 3 years.
That's great. And I would wonder if you could talk a little bit about variation. I know, again, I'm not clinical, but in my family with 3 siblings, one of my siblings has had findings, and they are 10 years younger than me. And thank goodness all of us have been doing our screenings and had to go more frequently than others of us. So talk a little bit about how that dynamic works within family genetics and how that care is personalized.
So the interesting thing about cancer is that it is genetically driven, in that there are changes in the genes that predispose people to cancer. But there's more than one. So some persons can have some changes and not others. And there are also environmental factors. So all of our environment works on our genes just like gene changes do. So you can have different, just like you look different than your siblings, your gene profile is going to be different from your siblings, and someone in your family group probably has some genetic change that predisposes them more to polyps or something else.
Great. Thank you for that. I'm sure that's very helpful for our listeners. If you are diagnosed and have to have a surgical procedure, can you talk a little bit about some of our minimally invasive programs?
So first, just globally, colorectal cancer is treated by 3 different modalities. There's surgery, there's chemotherapy, and there's radiation therapy. And care is personalized for every patient using some or all of those modalities, depending on where your cancer is and what stage it is. So some patients will come in and we will start with chemotherapy and work our way to surgery. And some patients will start with surgery and then determine if other treatments are needed. The beauty of the changes that have occurred in surgery over the last couple decades is that surgery has become miniaturized. So literally, I'm making a cut the size of my thumbnail in several little stab incisions to place the trocars, to put the instruments in, to do the surgery. And with that minimally invasive approach, which is primarily robotic, but also done laparoscopically, we can accomplish precisely the same cancer operations that we could do previously with big open incisions. And obviously, most people are familiar with minimally invasive surgery, but the big benefit is really in terms of recovery and getting back to life, work, and comfort faster. But there's also benefits in terms of decreased infection and in some cases, even better healing of the GI tract.
That's very helpful. Again, don't forget we have a QR code. If you have additional questions for our experts, please feel free to use the QR code. I do see another question that has come in again on colon cancer. What degree of separation, any type of cancer. So what degree of separation for any type of cancer in terms of it running in the family is important? So parent-child, obviously they're asking about is obviously a big deal, and a child of a parent who had cancer should get screened. But this viewer is asking what specifically about a great aunt or a great uncle or a second cousin, what do we worry about with regard to that? So Dr. Nagle, we'll start with you with regard to colon cancer.
We really look at first-degree relatives. So we want to know about your parents and your siblings and anyone in your immediate family cohort. Second-degree relatives, great aunts, probably are not as important in influencing your risk of colorectal cancer.
Okay, thank you for that. Dr. Dhamija, tell us about lung cancer and the family dynamic there.
Generally speaking, the genetic makeup of lung cancer in terms of its origin from a familial history is a little less understood than some of the other cancers that are being discussed. That being said, we do take into account lung cancer and other cancers in a patient's, again, first-degree relatives as well. Beyond that, unless it's in an abnormal, like a 30-year-old, for example, with lung cancer, that was a cousin or a second cousin or something, we don't take that much into account.
Okay, that's helpful. Thank you. And Dr. Georgakis, what is the thought process with regard to pancreatic cancer?
Actually, this is a great question because in pancreatic cancer, since we do not have such a robust data in terms of how to prevent it, we do see the relatives that they have pancreatic cancer as a means to identify which family members may develop pancreatic cancer. So for all the screening methods we have, we do employ first or second degree relatives having pancreatic cancer. For example, your father or your siblings, if someone has 2 siblings or a father that they have pancreatic cancer, including a gene, then these patients will go to a more rigorous system in order to see if they have pancreatic cancer as well. A family history of exocrine pancreatic cancer in more than 3 first and or second degree relatives from the same side of the family, even in the absence of gene, then that considered very high risk for pancreatic cancer. and these patients, they do get a very rigorous testing throughout their lifetime. There, as I said before, 2 genes that they don't require any family members having pancreatic cancer, but everything else, the BRCA genes, the genes that also can cause colon cancer, genes ATM, CDK2NA, then in these cases, we consider the family history important, and family history means that someone either first degree or second degree having pancreatic cancer.
Okay, great. Thank you for that question and the answers. That was very helpful, I think, for all of our viewers. I'd like to turn now and ask each of you, from your perspective as our experts, to talk about what you think is the most important thing from a prevention perspective. And April, if it's okay, let's start with you.
Sure. So the leading cause of lung cancer is smoking. And it's never too late to stop. So if you can, and if you're not ready to stop, if you can cut back on the amount of smoking you do, that's helpful with the goal of quitting. That's the most helpful. And if you're at risk for lung cancer, to get screened so that we can find it earlier when it has better outcomes.
Thank you, April. I appreciate that. Dr. Dhamija, anything else you'd like to add to that, or talk a little bit also about maybe some of the research that's underway in your specialty?
Absolutely. So I mirror Dr. Plank's discussion as well. I think it's important to not feel as if you're going to be judged when you come in, to be able to quit smoking and or get screened. You don't need to stop smoking to get screened, to understand some of the steps that may need to be implemented to be able to help quit and or to be able to treat any nodule that you see. Even if you don't have lung cancer, many people have nodules as well that sometimes get followed over time. And this is helpful to follow as well. In terms of research that's being done, we currently are doing multiple clinical trials in terms of understanding patients that may or may not be surgical candidates, introducing immunotherapy into our practices more and more. Additionally, we work in conjunction on our tumor board and often talk about all the clinical trials that one patient may be susceptible for or be a perfect candidate for.
That's great. Thank you so much. Dr. Georgakis, you talked a little bit about pancreatic cancer and how hard that is to be understood right now in today's science. Can you talk a little bit about any type of prevention measures other than the screening we've discussed, as well as research that is underway to help better understand that disease progression?
So unfortunately, there is no sure way to prevent pancreatic cancer. Some risk factors such as age, gender, race, and family history can't be controlled, but there are other things that we can control, like smoking. Smoking seems to be the cornerstone of most of our cancers. Body weight sometimes has been implicated in the making people more susceptible to pancreatic cancer. Physical activity also is paramount in keeping patients fit in order to be able to try to prevent pancreatic cancer. Avoid alcohol use. If you drink excessively, then you have a high risk of developing pancreatic cancer. How much is excessively? Try to limit the drinks to no more 1 drink per day for women and 2 drinks per day for men, mainly because of the fat content that we have. Also, limit exposure to certain chemicals in the workplace. There is a whole list of chemicals that exist in the American Cancer Society that they're being part of the International Agency for Research of Cancer and the U.S. National Toxicology Program, that they have been implicated in causing cancer. So if someone can go and read this list and try to limit the exposure to these chemicals, it's possible that they may prevent unnecessary pancreatic cancer.
Wonderful. Thank you for that. That's very helpful. Dr. Nagle, from your viewpoint, obviously we've talked a lot about smoking cessation and cancer overall, but with regard to colon cancer, other prevention ideas and thoughts from your perspective?
Yeah, I think the number one thing that people can do is maintain a healthy diet and lifestyle so that their body weight is in a recommended range, and that they're getting plenty of exercise and they're having regular bowel function. So smoking certainly affects all cancers, and we always advocate for stopping smoking. But it's really about diet, exercise, and body weight for colon cancer after smoking.
Okay. That's wonderful. Anything that you would like to add with regard to the research and some of the scientific discovery that's underway at Stony Brook Medicine?
So there are a few exciting things that are going on, and one of them is an extension of the personalized approach that we're using for each patient. Now, in recent years, they've developed tests that look for teeny fragments of the DNA of a cancer. So if we do surgery or you have a biopsy, we then send a portion of that specimen to a company who will make a test to look specifically for your cancer. And then we follow that with blood tests, with blood draws. And that's been really helpful in starting to understand how we can further tailor chemotherapy and other treatments for different patients. So we have clinical trials that we're actively enrolling in, looking at that issue. In other words, do you really have to have chemo based on these findings, or is there another way forward? So I think that's pretty exciting. We're also working with other medications like immunotherapy for patients at different stages to see if they can be combined in a way that will lead to better outcomes for patients.
Wonderful. Thank you, Dr. Nagle. I appreciate that. Let's go ahead and do just a final closing thoughts and comments from each of you. If we take away one piece of advice today, what is that? So April, if you'd like to go first, please.
Well, I hope that if you receive anything from us in the lung cancer center, that you know that you can come in and get screened, that the majority of our patients don't have a diagnosis of lung cancer, but those who do are often early stage. Early stage lung cancer has high cure rates, and we're happy to help you with quitting smoking. And we hope that if you find that you're at risk, if you're over age 50 and you're a current or a former smoker, that you'll give our office a call and we'll walk you through the process. We'd be happy to.
Thank you, April. I appreciate those comments. Dr. Dhamija.
Yeah, I again mirror April's comments. Just understand that we have an open door policy. If you want to speak with us or talk to us, and then just get a gauge of what it is that we have to offer, again, don't hesitate to call that number that's listed. We're here for you.
Thank you. Dr. Georgakis, what final closing thoughts do you have?
Thank you. What I have to say is to our prospective patients, listen to your body. Sometimes even the slightest symptom could be important. And especially if it keeps happening, it's a good time to talk to a doctor, more importantly, a primary care doctor who will be able to guide you. But if you don't have any, we're more than happy to provide you one. But also, sometimes I tell my patients when I follow them on lifelong screening that we're going to be friends for a very long time. And, you know, having friends seen over and over throughout the years is a very rewarding sentiment.
That's wonderful. I'm glad to hear that. Dr. Nagle, what are your closing thoughts?
I just so hope that everyone will choose to be screened. Unfortunately, we are still seeing a good number of patients come through who have stage 4 cancer because they've never had any screening previously, and we have much less success when the cancer is in an advanced stage. So much like there's no judgment in lung cancer screening and just come as you are, same thing in colorectal cancer. We'll meet you wherever you're starting from, and we'll figure out some test that will help you start the process and get screened.
Wonderful. Thank you for that. Thank you to our audience. We appreciate all of the interaction, very thoughtful questions, very helpful for everyone. Thank you to our Stony Brook experts. There's a lot of years of experience and knowledge here on this call today, or on this video today. We greatly appreciate the information you've shared with the patients and with the community. And finally, last but not least, this is being recorded, so it will be available and put on YouTube. If you want to share this with a friend at a later date, by all means, do that. We have shared our screening phone numbers, so please, if you have questions, reach out to one of our experts and we'll be happy to help. Thank you and have a great day.